I'm really very honored to receive this award. A few years ago, Anne Macaulay, I remember, won this award for her work with participatory action research and Indigenous communities. And she spoke about how this type of award allowed her to stick to her knitting, and really always inspired by Anne. And I'm actually not a knitter, but I am a juggler. And I'd like to think that this is going to allow me to stick to my juggling. I just wanted to declare some potential competing interests. The founder and CEO of CareTech, which is kind of my final mile project dream. Had several travel grants and other working with WHO and GRADE. Several CIHR funding that I'm going to be speaking a little bit about today, RCTs for plain language. Also been involved with the creation of a network for homeless health research and a network for the evidence-based recommendations for immigrants and refugees. I think it's really important just to acknowledge that my path has had many inspiring people, mentors. I'm sure you recognize some of these names here. And I also just want to include and do a call out for my students, Olivia Megwood, who's actually a PhD student, and Amar Syed, who just finished his master's in epidemiology with me. I think we need all kinds of people in our group to keep us moving forward. And I've been very fortunate, and I'm very, I think it's really important for us to mentor each other. Just like to take you here to the Montreal Museum of Fine Arts for a few minutes. The artist here, Gates, reconstituted gym floor planks and showing these markings on the gym floor to represent the many rules, the social orders that often we're exposed to at a young age, and how lack of access, lack of understanding can lead to lifelong disadvantage. I think in my experience with health equity research, and big part of my projects recently with long-term care visitation, COVID recommendations, meat processing workers during outbreaks, that understanding of the rules has been a critical thing. And I believe this is where we need these accessible recommendations for all. I think solving this is a global puzzle, and I don't think for a second it's easy or that it's a one-person job. I recently hired a Sudoku champ from Iran to work with my team, and he couldn't speak English very well, but he fit in beautifully with my team, who I considered expert puzzle solvers. And I think that's kind of how I approach a lot of my work. I think that anyone that has worked, and I'm sure all of you work with marginalized people and populations, also understand that there's also this real joy that can come with our work, with what I consider to be like breakouts and human success stories. I'm a big soccer fan, and Alphonso Davies is a refugee from Ghana, grew up in Edmonton, and has become Canada and really one of the world's top soccer players. And I think we all can think of people that have broken away and done so well. I feel like this is my work. So today I just wanted to give you some perspective of why I believe that health equity is really going to be critical, especially in our post-COVID, probably recession, and I think also just recovering from all the challenges from COVID. I believe there's really opportunities if we are focused on evidence-based recommendations that are accessible and understandable for all. And one of the things that I'm really focusing in on now is something that's scalable, so scalable interventions for family medicine. For me, it's really important that we continue to attract people with passion, creativity, motivation into family medicine. I believe that this is the core of who we are and our work. And I think it's something I also feel very committed to supporting and encouraging. In 2015, I found myself in Geneva at WHO in the UN during the Syrian refugee crisis. Found it very interesting positions considering my work. And I kind of came up with this photo back then, and I used this photo as my refugee Rorschach kind of test. And I often would use this with any presentations with any kind of students. And I asked people, what do you see? What do you see in this photograph? And I found that there was certainly a lot of tension in Europe at the time. A lot of people just see a burden on society, and they put fences up to try to stop that. Some people might just see a poor, destitute family. But I guess what I see, and I see is 3 future Canadian doctors here, and or maybe a soccer star. And I guess I feel like a lot of our health equity work is just allowing that to happen. And I also see community here, and I see a family, and I see a lot, like all my Syrian families, very committed to family and community. I see a lot of positive things in this photograph. I think I've always been a reluctant researcher, more of a clinician teacher that complained over and over that there was no recommendations to help us care for our refugee populations. Eventually, I was given some mentorship and a lot of support. And with 150 people, we developed the new methods and new approaches and actually came out with recommendations. I'm very proud that we scaled these up now, and we have very similar recommendations coming out of the US, Australasia. I was also from Europe, which I was able to lead the recommendations for all of Europe. So it's, I think, very powerful to have consistent, and I like to think understandable and evidence-based recommendations. Our recommendations, of course, touch a whole bunch of subjects, from the dental exam, which a lot of doctors didn't at first like, but I believe was very important for our refugees, unmet contraceptive needs, PTSD, of course, parasites, but it eliminated a lot of the testing for rare diseases that was not important. And I'm just as proud for these guidelines kind of de-screening and removing things that are not going to make a difference for a person's life. It's also, we were able to do a kind of a early low-tech project, but I think this is, I still get emails from around the world on this, where you can go into our website and you can actually put the country of origin of a refugee, and our program, which we programmed, will actually spit out what kind of things you should focus on in your prevention. And again, like it says, it's not about worrying about everything, it's about really precision and focusing and working, of course, with your refugee patients. With the methods that came from that, and with my involvement in that refugee project, I became a guideline methodologist. And I think this is what allowed us to do what I'm really excited about, is these first evidence-based homeless health guidelines. This is something I believe is very important. And at this level, we started to even focus in with our kind of community-driven approaches, using people with lived experience on our guideline panels. And so this is Terry in this photograph. We embedded a Toronto Star reporter in our conferences early in Montreal, and Terry was actually an author on 6 of our papers. We ended up scaling up to 18 peer-reviewed papers on this project. And Terry was constant contact with our office, and I just really want to recognize his key role in that project. Now, this project was, of course, led by many other Canadian family physicians across the country. We also published some parallel guidelines in the Canadian Family Physician as well as CMAJ. Unfortunately, we were lined up for about 65 interviews on March the 9th. And this, if people remember, was kind of the eve of when WHO declared COVID a pandemic. And so I was up at 4:30, and I had done about 3 or 4 interviews. And one of our other community scholars, Don Marie, had done maybe 2 or 3. And then all of a sudden the news came in that COVID was the news story. And so from that moment on, it was kind of like a sheet was pulled over our efforts. And I feel like we kind of disappeared. But I do believe in the post-COVID recession and challenges that are already appearing, that our work and our recommendations are incredibly important. Just one example, this is from our Lancet Public Health Systematic Review. And these permanent supportive housing programs, not just building affordable housing, but actual programs work. And they work for, we have these RCTs going on for 6 years, and they're working for like 6 years. And so there is a lot of help. And of course, we also identify income security and several other elements within this guideline. With COVID, I think I found myself luckily with a really interesting group of 70 countries being led by McMaster and Holger Schuermann, where we're actually the compilation of all COVID recommendations. I think we're up to 4,600 right now. And so we have a rec map that has categorizes, appraises, and we actually work every 6 o'clock every Tuesday morning with our partners from around the world to discuss all of the new recommendations. I've had the opportunity to be a leader on the plain language translation of these guidelines. So we have a whole initiative, new methods, develop easy to read and easy to understand recs that are balanced and that actually will, I think, be very useful for patients, but also for providers and also for policymakers. And now these recs are now going in, I think I have 8 languages here, but we have our recs being translated into about 16, 17 languages now. And so this is another experiment of how we can we translate plain language. And it turns out if you write in plain language, the artificial intelligence does a lot better job of giving you a first draft at translation. So we're fortunate with that. This is the project I really wanted to tell you about. It's still happening, and it's funded by the College of Family Physicians, the Glazier Award. We've worked really hard on this one for the last couple of years, and it's a project to look at apps and technology to reduce depressive symptoms and alcohol use in youth. I just want to recognize a list of authors, many of whom are medical students or graduate students, and very proud of this team. People will probably understand that, the depressive symptoms and alcohol use have more than doubled in youth during the COVID-19 pandemic. I think that's actually an underestimate. This was actually after 6 months of the pandemic. Also, it's important to realize that half of all mental health conditions start by age 14, and most of these are not detected or treated. And I think this is really important. And then mobile apps are emerging as potentially accessible, affordable, and maybe scalable. But the question is, are they effective? So we set up, of course, our PICO question to understand this. And I'm sure people have heard about a lot of the apps that are already publicly available. This is just from the App Store. In many of our studies, actually, we're evaluating these particular mobile apps that are available. A lot of them available for free for at least partial sessions, and already being used. We started with probably 10,000 citations, and we actually were able to select 32 eligible RCTs. And we were terrified to find that there's 200 registered RCTs coming. So we really need to get this published before we have to do an update. I think there's some really interesting findings in that these apps are becoming much more functional. The attrition rates are less than 8%, often 0. So people using these apps are actually completing the studies, which is really great. Definitely finding the affordability and convenience, often anonymous security. But I think it's really important, just before I show the results, to suggest that this is really early days. We have often had a lot of our studies were smaller sample sizes, there's often low intensity digital treatment interventions, and they're often short. This is partly because they are often using the free versions, or in some of the industry funded, these are often early studies, and so we really need more research on this area. What it is interesting is that when you do an industry-funded RCT, you basically lock down the app for 3 to 4 years, but the app isn't actually locked down in terms of its development, so it continues to improve in functionality. And so I think this is something that's a bit different than in a medication. So I think it's really exciting to see that virtually all these apps are getting better. So this is just some preliminary early findings on our depressive symptoms. This is our meta-analysis, and this is showing statistically significant what we'd call kind of lower effect sizes. And because it's difficult to sometimes come up with a sham, and this is for mindfulness apps, just to be clear, this is the design with mindfulness. So we're definitely seeing significance, but small effect sizes, which could have importance if you have a large population. And also, I believe still we need always more research. We also found actually more moderate effect sizes on the CBT-based apps, and I think this is also incredibly exciting. And again, because of I think still the difficulty with the placebo control, that we're finding kind of low to moderate certainties of these findings, and we certainly need more studies to confirm this. I think the other thing was very interesting. We found that a lot of designs don't seem to be working at all. So for at least just for depressive symptoms, but medication reminders or social health game, symptom self-monitoring, attention bias modification, these ones are not showing any significance. And so this is also, I think, going to be really important as we move forward. And we still have we have some similar findings, but I don't have them time today. The anxiety symptoms, actually exciting findings on all of these 4 areas. And also it's really important, of course, to think about what are the equity considerations. Digital literacy, of course. Now, from my experience, most of my refugees are arriving, a lot of my refugee youth arriving within they're with a smartphone, and if not, they're getting a smartphone quite soon. It's an incredible resource for the family, for the kids. I think it's also very exciting to think that we may be able to use apps to handle some of the stigma around the mental health screening for refugees, and maybe potentially provide more accessible, even some early mild treatment. But I also want to emphasize that talk therapy and in-person therapy still gives much stronger effects, but at the same time, there may be an opportunity for hybrid models. So I think I'm just really excited to have this new E. McWhinney Chair at Western. Really going to be working on forging new tools, new training pathways that allow for health technology and digital transformation. And I believe this will also be we need to start thinking new roles for the family physician to elevate us in terms of the patient-physician relationship. I think that also really important that we implement technology as assistance to care. One example is something happening at WHO where smart guidelines. So I think it's not to replace the family physician, but to actually make us more effective. And then I actually, like I said earlier, that for me, it's all about continuing to attract passionate and creative people into family medicine. I think that there's a lot of work to be done, and that would be on the top of my list for priorities.
Thank you very much, Kevin.
Thank you.
That was excellent, very interesting. I'm just looking if anyone has any questions, we have some time. I'll watch the chat. And while I'm watching the chat, I have a question of my own, Kevin. I don't know a lot about these apps, but I assume the app itself is, in these studies, is the intervention. The use of it is the intervention. Do the apps also collect the outcome data, the results, like whether or not they're drinking, depressive symptoms, anxiety symptoms? Is it both the intervention and the collector of outcomes?
I would say not always. I can see that when we're doing our risk of bias assessments on these studies, there's definitely a very good randomization. I think that one of the challenges was having this sham intervention. So most of it was wait listing and kind of not necessarily with a really good, so that the placebo group felt they were doing something. But so I'd say there was a weakness on that side. There was big efforts, of course, and with technology to not have anyone aware, like at least when they're collecting the data with the apps. But sometimes they was collected without the apps. There's other like SurveyMonkey, different ways to get it from the participants.
Yes.
I think that, yeah. So I would suggest that this is still early days, but the fact that I know that we have this whole new line of digital therapies, and this is just one of the leading ones in the health tech domain. There's actually several others that are going to be emerging. So I just think that just this idea that we have other things that could be helpful, that could actually reach people earlier. But of course, our people, and I'd be one of them, are already thinking hybrid models and how this can be used, potentially some of these people maybe really need the talk therapy as well. So there's going to be a lot of discussion as to how we're actually going to be. And right now, family doctors have probably no clue, and I'd be one of them, as to which of these apps works the best. We don't currently recommend them. Probably, I don't know if you could, but our first role is to do a very high quality. This is a Campbell systematic review that we will then allow people to look at the results. And we still, of course, need to be. I think just like we talked, vaccine hesitancy, I actually don't think is a bad thing. I think we also have like health tech or digital hesitancy. And I guess I think this is a fair game. We should be waiting and watching for good evidence, and making sure that there's no harms. I think one thing just to say, we haven't, most of our studies were 15 to 25-year-olds, which was actually great, which is our group, but they definitely were all in school, often college or universities. And I think that we don't have really any data on, let's say, people with, say, lower literacy, lower digital, I'm not even sure how it all interrelates. So I'd say we are still lacking certain groups of young people. And these studies don't show that yet.
Thank you. A couple of comments. One, Karen Chan says, amazing work, Kevin. And Randall Sargent, maybe? I second the award. You are a mentor to us all. And let's see what I have in the other set of. Doug Archibald says, congratulations on the award, Kevin. Thanks for walking through the work you have done over the years. Michael Green says, thanks, Kevin. Such an impactful body of work. You're a great example of how family medicine research and researchers are making a difference. Question, what project are you working on now that you are most excited about?
I believe that someone has to kind of help prepare the education for students and family medicine residents and family doctors around digital transformation. And so and with my partner, Dan Leger, we are actually working on potentially a very exciting care tech app, but can't talk about that one. But I can talk about my other side is I'm preparing programs, teaching, probably e-learning online, because I believe that family medicine and our young students need to understand what this digital transformation means and how they can play a role. Otherwise we'll just be like passive players, and I think this is a very dangerous situation. And I think they need, I know they need our experience, and we need to be in this digital transformation so we have positive outcomes for our patients. So I don't know if that's probably not a very clear answer, but let's just say I see digital transformation as a very important area. I know that it brings up a lot of anxiety and a lot of mixed feelings. I guess that's how I started my role in global health when I went into war zones and with MSF, and I definitely felt very uncomfortable there as well, insecure, not sure how to help, what to do. So I'm kind of feeling that same thing again as I kind of move into this role and try to provide this type of background leadership, which I believe will be very important over the next 10 years.
Thank you. And one final question from Randall Sargent. Your research interests are eclectic. Is there a theme that you are guided by? You might have sort of just answered that, but go ahead.
Yeah,
A theme.
I mean, like I want to make a difference, and I had a practice in Ottawa, and I definitely want to recognize my Ottawa colleagues. I don't know if I did that very well, and actually some Dalhousie colleagues since I worked some at Dal, but I had a practice for 21 years. More than half of my patients were refugees, and became Canadian citizens. And I was just floored by the ability of people to let me move on, and let me move on to this new, making a bigger impact for more people. So I had patients, refugee patients, who even had just had met and were feeling incredibly happy to found a trusted home. But they said, no, go and help more of us. And honestly, that's what I think about every day is that it's about trying to make a difference and to help more people. I think that's kind of where my shift has been a little bit. It's really hard to see I was seeing a little less patients, in London, but I definitely see myself as helping more in the future.